Good morning to all. I'm Dr.Subbiah. Today I'm going to discuss about a very important and common topic, Group A streptococcal infections from basics to up to date. So what are the two major groups of medically important gram-positive cocci, streptococci and staphylococci? How to differentiate streptococci from staphylococci biochemically? By doing catalase test. So what is catalase test? So it is done to check for the presence of enzyme catalase in bacteria that hydrolyzes hydrogen peroxide into water and oxygen. So if the bacteria possess catalase enzyme, it's evident by formation of bubbles in the test due to liberation of oxygen. Lack of catalase is indicated by absence of bubble production. Here upper one is a catalase positive, lower one is a catalase negative organism. Staphylococcus is a catalase positive cocci, Streptococcus is catalase negative cocci. Then how to differentiate Staphylococci from Streptococci by gram stain. Streptococci are usually arranged in chains. Chain formation is due to the cocci dividing in one plane only and daughter cells fail to separate completely. So it produces pyogenic infections with a tendency to spread. Whereas Staphylococci are arranged in clusters, so it produces localized lesions. How Streptococci are classified? So on the basis of their hemolytic properties on blood agar, there are three types of hemolysis are seen: alpha hemolysis, beta hemolysis and gamma hemolysis. Beta hemolysis means complete hemolysis. Alpha is partial hemolysis, it produces green color colonies. Gamma is a non-hemolytic bacteria. Streptococcus pyogenes is a beta hemolytic streptococci. Streptococcus viridans and pneumococci produce partial hemolysis. Enterococci are non-hemolytic. How the beta hemolytic streptococci are classified further? By a group specific polysaccharide carbohydrate located on the bacterial cell wall, the beta hemolytic streptococci is classified into 20 groups by Lancefield from A to V without I and J. So this is the beta Lancefield group of classification. So group A is a Streptococcus pyogenes, group B is Streptococci galaxiae, group C and G are Streptococci dysgalaxiae, and group D is Enterococci. So now coming to the group A streptococcal infections. So name the virulence protein in the cell wall of Streptococci pyogenes. It's a M protein. It inhibits phagocytosis. So what is Griffith typing? So group A Streptococcus can be subdivided into more than 220 serotypes on the basis of the M protein antigen, which is located on the cell surface and in fimbria that project from the outer surface of the cell. So this is the M protein which is present on the fimbria, which projects from the outer surface of the cell. So can a child develop recurrent group A streptococcal infections? Yes, because the M protein stimulates the production of protective antibodies that are type specific, that protects against infection with a homologous M type only, but much less against other M types. So the child can develop recurrent streptococcal infections due to other serotypes. So what are the toxins and enzymes produced by Streptococcus pyogenes? Hemolysins, pyrogenic exotoxin, streptokinase, deoxyribonucleases and hyaluronidase. So there are two types of hemolysins are there. One is streptolysin O and streptolysin S. Streptolysin O is oxygen labile, S is oxygen stable. Streptolysin O is antigenic. The anti-streptolysin O appears in sera following streptococcal infection. Estimation of ASO is a standard serologic procedure for the retrospective diagnosis of infection with Streptococcus pyogenes. The streptolysin S is an oxygen stable hemolysin. It is soluble in serum and it's a protein, but it's not antigenic. So streptolysin O and S it damage mammalian cells, thereby results in cell lysis and release of lysosomal enzymes. And the streptolysin S and O are produced by group C and group G streptococci also. Then second toxin is the pyrogenic exotoxin. So it's named erythrogenic because its intradermal injection produced an erythematous reaction in susceptible individuals. So the primary effect of the toxin is induction of fever. So it was renamed as streptococcal pyrogenic exotoxin. So they are super antigens that induce a massive release of inflammatory cytokines, thereby it cause fever, shock and tissue damage. The pyrogenic exotoxin cause various effects including the rashes seen in scarlet fever and streptococcal toxic shock syndrome. Name the enzyme that breaks down the fibrin barrier around the lesions and facilitates the spread of infection. It is streptokinase, also called as fibrinolysin. Streptokinase catalyzes conversion of plasminogen to plasmin, thereby it causes lysis of clots that facilitates the spread of organisms. Name the enzyme that liquefies the thick pus and responsible for thin serous character of streptococcal exudates. It's deoxyribonucleases, also called as streptodarnase. So streptodarnases degrade the viscous DNA in necrotizing tissue or exudates, again helps to spread the infection. Streptodarnase 4 antigenically distinct DNases are there, A, B, C and D, of which type B is most antigenic in human beings. So what's the diagnostic and therapeutic use of this deoxyribonucleases? So demonstration of anti-DNase antibody is useful in the retrospective diagnosis of skin infections caused by Streptococcus pyogenes. It's used therapeutically to liquefy localized collection of thick exudates as in empyema. Name the enzyme that favors the spread of infection along the intercellular spaces. Hyaluronidase. So hyaluronidase disrupts the organization of ground substance that facilitates the spread of infection. So now coming to the clinical features. What are the common infections caused by group A Streptococcus? It's classified into non-invasive infections, invasive infections and non-suppurative complications. Non-invasive infections are pharyngitis, otitis media, sinusitis, impetigo and cellulitis, erysipelas, perianal dermatitis, vulvovaginitis and dactylitis. Invasive infections are sepsis, focal infections with bacteremia, streptococcal toxic shock syndrome and necrotizing fasciitis. Non-suppurative complications are acute rheumatic fever, post-streptococcal glomerulonephritis, pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. Pharyngitis, otitis media and sinusitis will be discussed separately because it is a very big topic. Now I will start with the scarlet fever. It is also known as scarlatina. So what's the typical characteristic features of scarlet fever? So it produces a rash which is caused by the streptococcal pyrogenic exotoxin. It usually begins on the neck, face and upper trunk and generalizes to the remainder of the body over 1 to 2 days. Here palms and soles are usually spared. Diffuse erythematous sandpaper texture rash of scarlet fever is seen in this child. The erythema may be prominent in skin folds, it's called as pastia lines. Other findings are circumoral pallor, strawberry tongue and desquamation. So circumoral pallor is seen in this patient. The tongue is usually coated and the papillae are swollen. So after desquamation, the red end papillae are prominent, giving the tongue a strawberry appearance. So desquamation of the fingertips in a patient with scarlet fever occurs about 7 to 10 days after onset of illness. So third infection is the impetigo. It's known as pyoderma. So impetigo is an infection of the epidermis, erysipelas is an infection of the deeper dermis, and cellulitis involves the dermis and subcutaneous tissue. So impetigo, colonization of healthy skin by group A Streptococcus usually precedes the development of impetigo. Because this group A Streptococci cannot penetrate intact skin, impetigo and other skin infections usually occur at the site of open lesions like insect bites, chickenpox lesions, traumatic wounds and burns. So what are the two types of impetigo? The commonest one is the non-bullous impetigo, 70%, other is a bullous impetigo. Non-bullous impetigo initially a discrete papullovesicular lesion surrounded by a localized area of redness occurs, which is followed by the vesicles rapidly become purulent and covered with thick amber colored crust. It occurs commonly on the face and extremities. So bullous impetigo is less common, occurs most often in neonates and young infants. It is characterized by flaccid transparent bullae which is less than 3 cm in diameter on previously untraumatized skin. The usual distribution involves the face, buttocks, trunk, and perineum. Here, bulla sympatiga multiple vesicles with clear and turbid contents that rapidly coils to form flaccid bullae. So, what's the treatment? Topical therapy with mupirocin or retapamulin is appropriate for localized impetigo. Oral antibiotics like cephalexin and cefuroxyl are used for extensive lesions. Then erysipelas. Erysipelas on the face of a young child. Here you can see the distinct raised borders of the lesion. Then perianal dermatitis. Here well demarcated perianal erythema associated with anal pruritus, painful defecation, and occasionally blood-streaked stools are seen. And the commonly affected age group is the 2 to 7 years. The physical examination reveals a flat pink to beefy red perianal erythema with sharp margins that extends as far as 2 cm from the anus. The erythema sometimes may involve the vulva and vagina also in female children. So lesions may be very tender, and particularly when chronic, it may fissure and bleed. Systemic symptoms are unusual. Culture or a rapid streptococcal test of a perianal swab will yield group A streptococcal antigen. The treatment is topical mupirocin and oral amoxicillin. So vaginitis, group A streptococcus is a common cause of vaginitis in prepubertal girls. They usually have serous discharge with marked erythema and irritation of the vulvar area, accompanied by discomfort in walking and in urination. So etiologic diagnosis is best achieved via culture from a vaginal swab. Unlike other organisms found on cultures from patients with vulvovaginitis, group A streptococcus is not considered normal vaginal bacterial flora. The recommended treatment is 10-day course of amoxicillin. If vulvovaginitis is recurrent, one should consider testing the child for pharyngeal carrier status and decolonization. So invasive group A streptococcal infections. In invasive group A streptococcal infections, the organisms found in typically sterile sites such as blood, joint fluid or CSF. So two presentations that are important for the general pediatrician to quickly recognize are streptococcal toxic shock syndrome and acute necrotizing fasciitis. So streptococcal toxic shock syndrome consists of infection with group A streptococcus accompanied by hypotension and evidence of multi-organ failure. So this is the clinical criteria to diagnose toxic shock syndrome. The pillars of treatment are aggressive management of shock and organ failure, antibiotic therapy, and consideration of IVIG administration. So second is the group A streptococcal necrotizing fasciitis. It is characterized by extensive local necrosis of subcutaneous soft tissues and skin. If necrotizing fasciitis is suspected, immediate surgical exploration or biopsy is required to identify a deep soft tissue infection that should be debrided immediately. Antibiotic therapy is the same as streptococcal toxic shock syndrome. So dual therapy with a beta-lactamase resistant beta-lactam antimicrobial combined with clindamycin to mediate group A streptococcal toxin. The addition of vancomycin until MRSA can be ruled out. So summary, it's a group A streptococcus is a catalase negative gram-positive cocci. It produces complete hemolysis and blood agar. Pharyngitis and impetigo are the common infections. Penicillin is the drug of choice to treat infections caused by group A streptococcus. So these are the references. Thank you.